friends. Today our guest speaker is Dr. Samir Melinkari from Pune. He's going to speak to us on basics of CAR-T therapy. This webinar is brought to you by Mumbai Hematology Group. It is supported by ImmunoAct, Umenil, Unipath, Lucian, and Nirvin. It's managed by Perfect Square. I'm thankful to Team ImmunoAct and Team Immunil Therapeutics, Team Lucian, Nirvin, and Unipath, Mr. Yash, Mr. Kalpesh, and the Team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Samir Melinkari from Pune. All our discussants who are themselves eminent hematologists or medical oncologists, new participants for sparing your Sunday evening, morning, or afternoon. Next week on Saturday at 7 p.m. IST, we have Dr. Mark Lizzo speaking to us on adult ALL, how do I treat in 2025? He's from Rochester, USA. Next Sunday morning, 13th April at 11:30 a.m., we have Dr. Ashish Bajel speaking to us on future of allogenic transplant in AML. Our discussions today include a large number of colleagues and friends. Some of them are put up here alphabetically. And we have a few more here. Dr. Samir does not require an introduction. I'm just completing the formality. He's the head, Department of Hematology, Director, Blood and Marrow Transplantation at the prestigious Dinanath Mangeshkar Hospital, Pune. He did his MD Medicine from Vijay Medical College, Pune. Subsequently, he did DM in Clinical Hematology from CMC Vellore way back in 2007. Presently, he is also an Executive Committee member and Secretary of the Scientific Committee of Indian Society of Bone Marrow Transplantation. He will be lecturing on basics of CAR-T therapy. Over to you, Samir.
Thank you, sir, for the introduction. I'll just share my screen. Okay. So, second. Right. Okay, so I was told by Dr. Agarwal that this is going to be a lecture predominantly for students and right from undergraduate students to MD students and DM, DNB students are also the focus of today's audience. So I'm going to talk about the basics and how I generally go about treating a patient with CAR T-cell therapy. So this was the CAR revolution that came in India in 1983, and it changed the whole scenario of the CAR revolution in India. And in 2023, a slightly different CAR, as we can see, has brought a new revolution to a completely different field. And this is the CAR T-cell therapy that we're going to talk about today. So these are the fundamental concepts. So basically, T lymphocytes are the body's natural cancer killer cells, right? The cancer cells often escape the attack by T lymphocytes if the T lymphocytes are not able to bind effectively to the cancer cells and destroy them. So the chimeric antigen receptor T cells are genetically modified autologous T lymphocytes that are made to express a receptor that can correctly bind to the tumor antigen, thus destroying the cancer cell. That's the whole concept behind CAR T cell therapy. This is a Greek monster which has the face of a lion, the body of a goat, and the tail of a snake. And this Greek monster is called chimera. So essentially, a chimera is when you have more than one genetically different lineages in an individual, or in a cell, or in a in a protein. You call it as a chimera, right? So, for example, after you do a bone marrow transplantation, you have body is your own, the blood cells belong to the donor, so therefore you're a chimera. Similarly, if you have an antibody wherein you may have human a part of the FC is part is human, and the FAB fragment part may be of a mouse, so that again becomes a chimeric antibody. So similarly, receptor is basically CAR T cell receptor is basically a cell which has two different sort of genetically different modified lineages. That's why we call it as a chimeric. All right. So what are the diseases in which CAR T cell therapy is currently approved? And these are B cell acute lymphoblastic leukemia, B cell lymphomas, and multiple myeloma. Where active research is going on, it's a host of autoimmune disorders, the most important one being SLE, but a host of others are also there. Then solid organ cancers, extensive investigations ongoing, and infections such as viral infections like HIV and CMV have also been on the research for CAR T cell therapy. Okay, now scenarios where one would consider doing a CAR T cell therapy. So for a patient with B cell lymphoma or acute lymphoblastic leukemia, a patient who's received chemotherapy, but the disease persists or responds initially, but then relapses later on. Within a year of the completion of chemotherapy, the disease has recurred. In that scenario, you can consider a CAR T cell therapy. Or if the patient has undergone the standard of care for a relapsed leukemia or lymphoma, which is a bone marrow transplant, that has also been done, and now the patient has relapsed. That's another scenario where you can consider doing a CAR T cell therapy. Now, in multiple myeloma, it is slightly different, because when you're looking at lymphoma or ALL, you're aiming at cure with CAR T cell therapy, right? You want the disease to be completely eradicated and never come back. Whereas multiple myeloma, whatever treatment you do is generally, we talk about just controlling the disease for a longer period of time. It doesn't cure the myeloma. So in a myeloma, the current approval is after 3+ lines of treatment. A patient has to have received 3 lines of treatment, which generally includes a proteasome inhibitor and an IMID and a CD38 monoclonal antibody. After these, the patient has relapsed, and then that's the time when you're going to do a CAR T cell therapy. Right. That's your normal TCR receptor on the left side, and these are the CAR formats that have been come up. The various generations of CAR T cells are there. In the first generation, as you can see, you have only the heavy chain and the light chain. A single heavy chain and a single light chain is there. There's a hinge. There's a transmembrane domain, and there is the intercytoplasmic domain, which is the zeta chain. Then in the second generation, it was realized that this construct alone is not enough, because you need to have what is called as a co-stimulatory molecule as well. Now, there are 2 co-stimulatory molecules. One is the CD28 and one is the 41BB. Right. So either one of these co-stimulatory molecules is also added on in the second generation. That makes the CAR T much more, the CAR receptor much more effective in terms of mounting an immune response. And then you have the third generation, which you have both the co-stimulatory domains available. And in the fourth, where apart from the CAR T, it also releases certain other cytokines into the blood, right, for a better efficacy. But most of the available CAR T products that are available commercially right now and are licensed for use, these are all second generation CAR Ts, right? So that's what most of us are using. Now, when you decide to take a patient up for CAR T cell therapy, how do you go about it, right? So the first step is that you're going to extract or harvest the patient's own T lymphocytes and send them to the lab. So the patient goes on to an apheresis machine in the blood bank. His cells are apheresed, and you extract the mononuclear cells, which are the lymphocytes, and you send them in a dry ice to the company that is going to manufacture the CAR T cells, right? In the lab, there is a process of T cell activation. Then there is the process of activation and, of course, separation, right? You separate all the T cells, and then you have to transduce the CAR T cells. I'll explain this a little bit later. And then you expand those cells. Once the CAR Ts have been construct is formed, when the CARs have been generated, you expand them to achieve a desired volume. and then you infuse them into the patient. Before infusing them into the patient would have received a particular lymphodepleting chemotherapy, which is almost always fludarabine for 3 days and cyclophosphamide for 3 days, both on the same days, right? So fludarabine, cyclophosphamide. The idea of this lymphodepleting chemotherapy is to prevent, is to sort of destroy some of the recipient's own lymphocytes, which might, cause rejection of the infused CAR T cells. It's a short chemotherapy, not a very intensive one. And prior to giving the lymphodepletion, in case the patient's disease burden is very intensive, then you want to reduce the tumor bulk by giving a bridging chemotherapy while these CAR Ts are being prepared. What is the typical time from sending them to the lab and getting the CAR T cells ready? It is about 2 weeks, plus or minus 2-3 days here and there. Roughly 2 weeks is the time that is required for production of these CAR T cells. So you may decide to give bridging chemotherapy and then decide to give the lymphodepleting chemotherapy followed by infusion of the CAR T cells. So the important step in this whole thing is the transduction of T cells, right? So what exactly does this mean? This basically involves transferring the gene of interest into the T cells, right? So you want to have a completely different T cell receptor that these T lymphocytes are expressing, which has the correct ability to bind to the tumor antigen, right? Now, how do you make this T cell receptor to be expressed? You have to edit and change the gene that produces this T cell receptor. Now, how do you get this gene inside the T lymphocyte? Right. So what you do is you make up that gene construct that you want and put it inside a lentivirus. The commonest virus that you use is a lentivirus. So the lentivirus is then it carries the gene of interest which codes for this T cell construct, and the patient's T lymphocytes are infected with the lentivirus in the lab, so that the lentivirus goes in and it imparts its DNA to the T lymphocytes DNA, which it integrates in that place, and then the T cell receptor is expressed by the gene of the T lymphocyte. So, for example, this is a anti-BCMA CAR T lentivirus, just to show you. So this is the BCMA CAR construct, and this is the rest of the genome of the T lymphocyte of the lentivirus. And this then is infected with the T cells, and that's the BCMA construct that you want, and that's how that gets expressed by the T lymphocyte. Now, how do you edit and cut the DNA, whichever area of the DNA you want to cut? This is now done by a system called as the CRISPR-Cas9, which is nothing but DNA scissors. You can literally cut, copy, and paste any part of the DNA wherever you want. You can design a Cas9 scissor, Cas9 for that particular purpose, and then you can get your gene of interest, which sticks inside the recipient, inside the T lymphocytes. So the transduction of T cells can be done by two systems, right? The first is an open system, and the second is a closed or a semi-automated system. So the open system is where you actually have, these clean rooms. You have a lab in which you have clean rooms with a GMP facility. You enter inside the clean room, hooded like this, and then the process of infecting the T lymphocytes with the lentivirus is actually done manually in the lab, right? Yeah, so that's called the open transduction system. Now, what is the problem with open transduction and what is the advantage, right? So the manufacturing process of CAR T cells it's a complex procedure here, and it's labor intensive, right? You've got to do everything manually. And you need a large facility. You need a large lab where you have lots of people who are actually doing all this correctly. It is expensive to establish and requires more personnel, right? But the advantage is that there is no kit. I'll come to the other system where you need an expensive kit to do the whole thing, where this is done manually, and therefore the cost of production of an individual product would be much lower. And the most important is that you can produce multiple CAR T products in a month, right? There's no limit to how many you can prepare. You can prepare lots of CAR T products in a month. So the ability to produce more CAR Ts is higher with this sort of transduction process. Whereas the other is called as the closed transduction process, in which there is a machine which does all of this for you, right? So there are two machines which are available. One is the Clinimax Prodigy from Miltenyi Biotech, a German company, and the other is Sapaxi Pro from GE Healthcare. Okay. Now, in these machines, the sample preparation, the T cell enrichment, the stimulation, the viral transduction, expansion, and the final formulation is all done inside this machine itself. So you just infuse the cells there. At various time points, you have to add on various reagents or chemicals, push them inside the machine, and the machine does all of this process for you and gives you the final product, which is a prepared, which is where you have the transduced CAR T cells all ready, expanded and ready to use, right? The time required for this production again is 10 to 14 days, is roughly the same with both the processes. Right. So here you see, you cannot just keep the machine anywhere outside in your lab. You have to have a clean room, a GMP facility for this as well. Okay. And the machine has to be kept only inside a GMP facility. So it's not an easy thing to do at all, to maintain a GMP facility. That's a little bit about the Clinimax Prodigy machine. This is the most widely used machine for production of CAR T cells. It's a German company which basically got it shot in 2014. It acquired Lentigene, which is a premier company which was working with the lentiviruses, and therefore it acquired this lentiviral vector technology from Lentigene, and therefore it also acquired this adapter CAR T cell technology, and therefore it started manufacturing CAR T cells. Now, what is the advantage of this closed system of transduction? All in one solution. You just put it inside the machine. Machine will do the job for you. It's not labor intensive as the open system. But the problem is that the kit required for each vector is very expensive, right? Almost something, I believe, I don't know the exact cost now, but I believe somewhere close to about 25 lakhs or so for each kit. And one machine can produce up to 2 CAR T cells a month, right? So once you fill up one machine, it's going to get locked for about 2 weeks, right? So about two products will be produced by one machine. So you have to have multiple such machines, right? If you want to have a high scale of production of CAR T cells. Right. So now this is a CAR T cell development program that from discovery to FDA approval. Won't go through this in too much detail, but it's not something which is which was thought of very recently. It's been thought of since years, right from 1989, where Shah et al. 1993 prepared the first single chain variable fragment CAR, and then it was shown to have demonstrable anti-tumor activity. In 2006, the first clinical data was shown, and in 2010, the first clinical data with CD19 CAR was shown again in a patient with follicular lymphoma. Then came in 2013 the first clinical data with CD19 CAR in ALL by Group and Carl June. And finally, in 2017, we got the approvals from FDA for the first CAR T cell products, that is Kymriah and Yescarta. So this was the paper by Rosenberg in 2010 in a patient with follicular lymphoma, but again, not done as a formal trial. The first trial that was done, which showed the efficacy of CAR T cell therapy in acute lymphoblastic leukemia, was the Eliana trial. This was a product called Tysogen Leclusil, and which is now marketed by Novartis as Kymriah. This was in pediatric patients and young adults with relapsed refractory acute lymphoblastic leukemia. In this study, the pediatric patients who had more than 5% lymphoblasts in the marrow were included, and those who had extramedullary disease or CNS disease were excluded. Patients received fludarabine cyclophosphamide conditioning followed by Tysogen Leclusil infusion, and look at the response rate. So in a patient category which is otherwise sort of they had no treatment options left beyond this, it showed an excellent response rate of close to about a CR of about 82%, and 98% patients who had achieved a CR also achieved MRD negativity within the bone marrow. The relapse-free survival amongst responders at 12 months, 66%, 18 months, 66%, 24 months, 62%, right? So at 12 months, if you got a good response, you're likely that you're going to be responding long term. That's the 5-year relapse-free survival of 44%. And most importantly, generally the chemotherapy or even bone marrow transplant for that matter it generally doesn't work all that well in patients who have a higher cytogenetic risk factor. If you have very bad karyotype or risk factors, genetic risk factors, then the results tend to be poorer with chemotherapy and bone marrow transplant. But that's not truly the case with CAR T cell therapy. It works across the cytogenetic risk categories. As you can see, the relapse-free survival was nearly similar, whether it is high, intermediate, or favorable risk factors, and the overall survival also was the same. Okay, so now apart from these two products, more products subsequently came in. In 2017, you had tisagenlecleucel for relapsed refractory B-ALL and axicabtagene lecleucel, which was Yescarta, approved for large B-cell lymphoma after 2 lines of treatment in 2017 again. Then Kymriah came for large B-cell lymphoma as well, against it was CD19 CAR T therapy. In 2020, you had another product called brexucabtagene autoleucel or Tecartus for relapsed refractory mantle cell lymphoma. Then in 2021 came lisocabtagene, or called Breyanzi, approved again for large B-cell lymphoma after 2 lines of failure, 2021. And similarly, axicabtagene was approved for follicular lymphoma in 2021. For multiple myeloma in 2021, you had ID-cell, idCabtagene autoleucel, and subsequently an even better product called ciltacabtagene autoleucel, which came for, which was called Carvykti. This is from Johnson & Johnson, and this was approved in 2022. Okay, so I showed you one trial for the most important trial for ALL. I'm going to show you one trial which showed the efficacy in large B-cell lymphoma. Now, obviously, I cannot show all the trials because there are multiple trials being shown in lymphomas as well as ALL as well as myeloma. So I'm going to highlight only one trial from each for each disease category. So this was axicabtagene ciloleucel for refractory large B-cell lymphoma. It's basically by Kite Pharma, marketed by Kite Pharma right now, but the construct was prepared in the National Cancer Institute at the National Institute of Health, Bethesda. It's an autologous anti-CD19 CAR T cell therapy. And patients that were included in this were large B-cell lymphoma and primary mediastinal large B-cell lymphoma. So these patients were treated, and just look at the overall response rate of upward of 80% in both the categories. And majority of these patients actually achieved a complete response. The blue is the complete response, and that's the partial response. Yeah, that's right. So in this, you can see what are the risk factors for. Sorry, so what was the what was the category where the ORR was like really significant. You can see here. The most important one was the disease bulk, right? So if you had a bulky disease and you're trying to do a CAR T cell therapy, then the responses were not as good. Right. And of course, if you didn't have a CD19 at all, then of course it's not going to be good. But for all other categories, it's the same, right? Whether it's extranodal disease, whether what the IPS score is, it doesn't matter. It works equally good, whether it's a high IPS score or a low IPS score, or the stage of the disease is stage 1 or stage 4. It doesn't matter so much. The cell of origin, again, doesn't matter so much. Most important is the disease bulk. If you have a high bulk disease, then your chances of response to CAR T cell therapy is going to be lower than if you have lower bulk disease. That's the duration of response. As you can see, this is those who achieved a complete response were obviously going to have a much better duration of response than those who had just an objective response or a partial response. Partial response patients don't do well at all. You have to have a complete response. That means at the end of 1 month or 3 months of your CAR T cell therapy for lymphoma, the PET scan must be absolutely clean, and that indicates that you've got a higher chance of being cured. That was the progression-free survival and the overall survival for these patients. The PFS of somewhere around 40%, and overall survival was even higher. Now, what's happening in India? So for a long time, the CAR T cell therapy was available abroad, but in India, this wasn't happening, and our patients had to travel abroad to get these treatments done. But then thanks to Dr. Rahul Purwar, who is a professor of biotechnology at IIT Bombay, he developed the first indigenous vector for CAR T-cell therapy for CD19, and along with Dr. Gaurav Narula from Tata Medical, from TMH Mumbai, they developed the first CAR T-cell therapy for India in collaboration with National Cancer Institute and others from the US. And this was a CD19 product, in which this was the results of which I'm going to show you shortly. And this was initially presented in the American Society of Hematology annual meeting, and this has also recently, just last month, been published in Lancet Hematology. The product name is Telicaptogene autoleucel, and this was used for relapsed refractory B-cell malignancies, including B-ALL and B lymphomas. In this study, this was the outline of the study, in which 64 patients, ultimately about 53 patients were evaluable. Out of these, 14 were leukemia and 43 were lymphoma. And that's the dose that was roughly used. Roughly up to about 15 million cells were used in the study. And these were the biological characteristics of the patient, which I won't discuss in too much detail. But as you can see, in ALL, the disease, the treatment was done with a really high blast percentage. The median blast percentage was 61%. That's really, really bulky, Also, many of the patients, I was also part of this study, so I know some of the details, where we had really included sick patients, who had even bulky lymphoma at the time of taking these patients up for CAR T-cell therapy. And these were the responses, right? So this is for lymphoma and this is for leukemia. Lymphoma, a larger number of patients. The overall response rate was 68% for lymphoma, and for leukemia, it was 72%. The CR was 37% for lymphoma and 72% for leukemia. So in general, we notice that it works better for ALL than for lymphoma. But having said that, I can, the real world data with this product is far better, because at the time when this product was when the study was being done, everybody who was in this trial was a little naive, and we didn't know what sort of patients were the best ones that could be taken up for the study. So all kinds of sick patients were taken up. And probably that's the reason why in lymphoma you are having lesser, CRs. If you can select the patient more appropriately, the results are going to be better. So in this study, the cytokine release syndrome was seen in about 70% patients, but severe cytokine release was seen in only 5% patients, and no ICANS was seen. And hypogammaglobulinemia incidence was again pretty high, which is expected. So this is the other product that is available in India, and this is from a company called Immunil Therapeutics. The product that they have is called Varnemcaptogene autoleucel. And this is actually a Spanish vector designed in Spain, and this vector is being imported from there. So the Telicaptogene is prepared by a manual transduction process, right? The one which I described. So ImmunoAct is a big company in which they have the open system for transduction, whereas in Immunil, they have the closed system for transduction. This is done on the Clinimax Prodigy machine. So let's look at, so the studies were primarily done in Narayana Rudhralaya, Bangalore. And these are the efficacy outcomes. The overall response rate at day 90 was 83%. And by day 28 was for BNHL, and 91% for B at day 28. So in general, the cases that were selected for this was, the number was lower, 12 for ALL and 12 for lymphoma. But these cases were probably a little more wisely chosen, and that is why you can see that the results are even better, right? So this was the 6-month ORR. That's the 12-month ORR for you, and the 18-month ORR. And you can see that the 12-month PFS was 50% here, 12-month overall survival of about 75%. And they claim that, if you compare, of course, these are very small numbers as compared to these numbers, but the overall response rates, the CR rates, the PR rates are all quite similar with the with Guanine Captogen as compared to the other internationally available FDA approved CAR T cell products. All right. Now, what about comparison between CAR T cell therapy versus allogeneic bone marrow transplant or hematopoietic stem cell transplant for B-ALL or lymphoma? Now, the standard of care for any patient who has relapsed for ALL is that you get the disease under control with whatever chemoimmunotherapy, achieve a minimal residual disease negativity, and then follow it up with an allogeneic bone marrow transplant. So it's been a standard of care for years, and we've got sufficient experience with the how to go about this process, and we know what the results are, right? Now, CAR T cell therapy is a much newer form of therapy, and it can work for patients who are relapsed post allogeneic transplant, or it may work for patients who, the problem is that you cannot predict which patient is going to respond and be cured with the CAR T cell therapy versus which patient is going to respond better to an allogeneic transplant. So that dilemma is always there, right? Which of these treatments are you going to select? Now, first, let's look at the rough chances of disease-free survival. The chance of DFS with the CAR T cell therapy is between 40 to 60% for, as you've seen from the literature, for whether it's ALL or lymphoma. With an allogeneic transplant, the chance of cure is again the same. It's about roughly between 40 to 60%. Most transplanters would agree with this. The problem is that the mortality with CAR T is only about 2 to 3%, whereas with an allogeneic transplant, especially if it's going to be a mismatched transplant, then it can be as high as 15 to 20%. So CAR T is a safer treatment than allotransplant. Allotransplant could probably cure more patients, but the problem is 20% are going to die, and therefore the ultimate cure rate comes down, right? Now, what is feasible advantage? CAR T cell therapy is much less toxic treatment, and therefore it's feasible at an advanced stage, whereas allotransplant is not. And the most important problem is the cost. CAR T cell therapy is going to cost somewhere in the 40 lakh range, roughly plus minus. And allogeneic transplant is somewhere between 15 to 25 lakhs. Many times, the question comes, so should I transplant post CAR T cell therapy? I've achieved response with CAR T cell therapy. I don't want this patient to respond. I know that the chance of cure is going to be somewhere around 40%. 60% are going to actually relapse again. So after CAR T, can I do a bone marrow transplant? Yes, you can, in order to improve your chances of cure and reduce the chances of relapse. But with knowing the fact that about 15-20% chance that your patient will actually die, and he were probably going to be cured with the CAR T alone, right? So that question, that dilemma can never be answered as yet. But in general, some of the products now have come up with their labels or their recommendations. So from the Zuma 3 trial with the Axicell, Eliana, and the Memorial Sloan Kettering product, they say, no, don't transplant, do only CAR T and wait, take your chances. The chance of cure is pretty good, 50% roughly. Whereas the NIH product, the Fred Hutch product, and many of the Chinese products, they say, yes, please proceed, don't take a chance, get into a good, MRD negative state, or a PET CT, a good CR, and then do a transplant and subsequently try and cure the disease. Now, another approach that has been taken is use of next generation sequencing, minimal residual disease evaluation, 1 into 10 to the power 6 cell, that's the sensitivity, post CAR T cell therapy to make the transplant decision. So if you have a NGS MRD negative, don't do a transplant. NGS MRD positive, yes, do a transplant. Right, then coming to the toxicities of CAR T cell therapy. So the most important toxicity of CAR T cell therapy is the cytokine release syndrome. That's the commonest, but there are others. The second one is the immune effector cell-mediated neurotoxicity syndrome, the immune effector cell-mediated hemophagocytic syndrome, then the CAR T cell-mediated cytopenia, and hypogammaglobulinemia. These are some of the common side effects of CAR T cell therapy. I'll discuss these a little bit. So cytokine release syndrome occurs naturally because these are angry cells designed to react when they see a target, right? So when they suddenly see a target, all the cells, they'll suddenly start expanding in the body, and they're going to release their cytokines, which may cause more harm, right? So this this is the ASTCT, the American Society of Transplantation and Cellular Therapies consensus grading for CAR T cell therapy for CRS. And in grade 1, you have only fever. So the three manifestations of cytokine release syndrome are fever, second hypotension, and third is hypoxia. Right. So with grade 1, you have only fever. Grade 2, you have fever plus hypotension responding to IV fluids and or slight hypoxia. Grade 3 is fever plus hypotension and requiring one inotrope and or hypoxia requiring more than 6 liters, so severe hypoxia. And grade 4 is fever with hypotension requiring multiple vasopressors or hypoxia requiring CPAP, BiPAP, or intubation, right? So that's the simple grading of CRS. In grade 1 CRS, just managed as neutropenic fever. Patient is typically neutropenic at this point of time. It's very difficult to say whether this is CRS or actually neutropenic infection. So you always draw blood culture, start antibiotics, and just observe the fever. If the fever starts converting into, manifesting as hypotension or hypoxia, immediately give 1 dose of tocilizumab. Right? Tocilizumab is an IL-6 antagonist. You give 1 dose initially and then see if everything works. If everything settles with 1 dose, don't give any more doses. But if it doesn't settle, you can give Q8 hourly for 3 doses max, if not improving, right? Max up to 4 doses. If no improvement within 24 hours of supportive care and tocilizumab, also add on dexamethasone at this particular dose. If there is grade 3, shift to the ICU immediately. Give tocilizumab as for grade 2, that is 3 doses, and dexamethasone 6 hourly. And grade 4, again, give intensive support, tocilizumab and solumedrol in high doses. And majority of CRS will actually respond. Very few patients will actually die of CRS. If you get it in time, you miss it, the patient can die. But if you recognize it early, you treat it, it almost always will respond well. The second is if you have a disease inside the CNS, right? If you have got a, say, ALL with some cells in the brain, the same T lymphocytes, the CAR T cells are going to penetrate the blood-brain barrier, going to the CNS and cause CRS over there. And that's what we mean by ICANS. In ICANS, these are the grading of ICANS. Won't go through this in too much detail, but gradually, initially he's awake. Gradually, he starts becoming more and more sleepy. And in the worst case scenario, develops paralysis or becomes comatose with prolonged seizures. And the treatment for all of these is basically dexamethasone or solumedrol. Solumedrol you would give in grade 4. Otherwise, dexamethasone itself works, and almost always they will recover well. The next complication is hypogammaglobulinemia, very important complication. There is a profound, since this is a CD19 CAR T, it is going to destroy all the B lymphocytes and plasma cells in case it's a BCMA when you're doing it for multiple myeloma. So the lymphocytes and or plasma cells are going to be completely wiped out. And an IgG level has to be monitored monthly. The moment you see an IgG level of less than 400 milligrams per deciliter, it predisposes to severe viral and bacterial infections. And then you have to give IV immunoglobulins at a dose of 400 milligrams per kg, single dose, if this is the case, to prevent infections. The next complication is called as IEC-HS. So as you all may be knowing, what is hemophagocytic lymphohistiocytosis. So in response to a particular antigen, your lymphocytes activate macrophages. Macrophages are intensively activated, and then they start phagocytizing your own tissues, your own cells, and that causes severe cytokainemia and potential death if this is not recognized and treated. And this we know occurs as there's a primary HLH, there is a secondary HLH which can happen in response to many infections and also in response to lymphomas like malignancies. In the autoimmune disorder situation, it's called as macrophage activation syndrome. And the same thing can happen after CAR T cell therapy. Generally, patients who develop ICHS are typically patients who have developed a CRS, right? But this usually occurs later after the CRS has resolved. So as the CRS develops, CRS typically develops within 24 to most commonly between 7-8 days post CAR T, right? Can happen later on also, but within the first week is the commonest period when you have cytokine release syndrome. And as you treat it and the cytokine release syndrome settles down over the next maybe 2 to 4 days or 5 days, that's the time when a few days later, you'll start having IEC-HS. And how does this manifest? New onset of fever which has settled down with, has now recurred again. and you start developing cytopenia. You check the serum ferritin levels, they are sky high. You look for coagulopathy, you see the fibrinogen is very low, triglycerides are raised. You have transaminitis, is a very common manifestation of HLH, and organ dysfunction. And the treatment for this is dexamethasone, but more importantly, a drug called anakinra, which is an IL-1 antagonist. This is a drug of choice for treatment of ICHS because it doesn't cause much of cytopenia and it is very effective. And if in case this doesn't work, then you use ruxolitinib, which is available. So anakinra is very expensive, not easily available, but dexamethasone and rux are easily available in India. So you treat these, and if you treat appropriately, the patient is likely to resolve well. But this is a troublesome complication to handle, ICHS. Okay, now I'm just going to discuss in the next 5-10 minutes about how I would plan a CAR T cell therapy for a B-ALL or lymphoma, right? So supposing you have a patient with relapsed refractory disease, I would first, I'm planning to do the CAR T cell therapy. The first thing I would look is, and I would see the tumor burden. If the lesser the burden, the more the efficacy, and the less of the lesser chance of developing CRS. So if you have a bigger tumor burden, more antigens the CAR T cells see, they will expand more and cause more CRS, right? And ICHS subsequently. Minimal tumor burden is there, you proceed to CAR T directly, right? Straight away do the CAR T, get rid of the disease. If you have a slightly higher disease burden, say lymph nodes in 2-3 different places, reasonably, larger in size, then you would harvest the T cells and then give one cycle of bridging chemotherapy, 1 or 2 cycles of bridging chemotherapy. And the bridging chemotherapy could be anything. People would know. There's no fixed bridging that you may decide. You have to look at the patient's profile and decide. It may be immunotherapy and or low dose chemotherapy. The idea is to just get the disease down to as minimum as possible and then infuse the CAR T cells after recovery from the bridging cycle. So CAR T cells, when they're prepared over the next 2 weeks, they can always be kept in the frozen state for the next 1 or 2 months or 3 months, whatever you want. They will be kept in the lab. Only when you ask them to issue it, they will issue them, right? So you get the disease down under control, then infuse the CAR T cells. Now, if the patient has a really high disease burden, like, more than 50% blast in the marrow, or, 30-40% blast in the marrow, or a large mass, 10 centimeter bulky mass of lymphoma, then I avoid collecting the T lymphocytes prior to doing the bridging therapy, right? Like here, if it's minimum disease, I would just sort of harvest the T cells and then give the bridging and infuse the T cells. Here, I would first give the bridging and then collect the cells. Why? Because if I collect the cells, immediately the patient is going to have to pay those 30-40 lakhs to the lab, right? And after this, if with your bridging therapy, the disease doesn't respond and it keeps on increasing, then the CAR T cell is less likely to work and you've lost your money as well. That's a practical problem that we face. And therefore, I would first do bridging, ensure that I am able to get the disease down at least temporarily under control, and then harvest T lymphocytes and do the CAR T cell therapy subsequently. Now, what is the dose of CAR T cells that we use? This is with the Indian product, of course. So with ALL, the cell dose that we usually use is about up to 5 million cells per kg. And for lymphoma, we use a higher dose that is about 5 to 10 million cells per kg. Now, after you infuse the CAR T cells and you've gone through the whole gamut of complications, you handle it. Sometimes it goes very, very smoothly. Patient is admitted, you infuse the CAR T cells, nothing happens, patient just goes home, right? It's as simple as that. Sometimes it can be a horrendous course. So you have to monitor the lymphocyte subset analysis on a monthly basis, right? So now, important thing is that the CAR T cells persistence is not essential. It doesn't mean that if your CAR T cells have lasted for 1 year, only then the chance of your disease being cured is good. The CAR T cells have to actually destroy the tumor. It's not important to just persist, right? So if they've stayed for a shorter period of time, but they've actually destroyed the entire tumor, and the CAR T cells have not persisted subsequently, that is still good for us. So we don't monitor the CAR T cells persistence. What we look at is the B cell aplasia. So if your CAR T cells have done their job correctly, then your B cells, CD19 positive normal B lymphocytes should be very minimal. So if you look at them, they'll be very, very low in number. So about 6 months of B cell aplasia must be there in order it's a surrogate indicator that your CAR T therapy has worked well. Then monitor the IgG levels, as I mentioned, monitor closely for infections, and vaccinate post CAR T starting about 1 year, just like you do for a bone marrow transplant. Important don'ts before doing CAR T when you plan the CAR T. Avoid using drugs that would affect the T lymphocyte function and number for a prolonged period of time. So the two drugs that you must avoid are purine nucleoside analogs and bendamustine. Don't use these like fludarabine, cladribine. Don't use these drugs before you do a CAR T cell therapy. And whatever drugs you've used for bridging, allow a sufficient washout period before you actually harvest your cells. A little bit about CAR T-cell therapy for multiple myeloma. So as you can see, whatever drugs that you have for multiple myeloma, you can see that the CAR T-cell therapy is the one that has really good results. The overall response rates are excellent, and they could in the future actually replace autologous stem cell transplant for multiple myeloma. And this is the two products that are FDA approved: the ID-cell and the cilta-cel. And as you can see, I'll just show you the cilta-cel data. For a patient who are triple refractory, they've received a median of 6 prior lines of treatment. Triple refractory disease, that means daratumumab, one prior, IMiD, and one proteasome inhibitor resistant. 87% patient belong to that category, and the response rate was close to 100%, right? Very high response rate with a CR of about 80%. And that was the CARTITUDE-1 study, in which it showed the chance of your being in good control of disease at 3 years was about almost 50%. So half your patients after 3 years with cilta-cel are going to remain disease-free. And the cilta-cel was then compared with standard of care, such as combination of daratumumab, pomalidomide, dexamethasone. And it was shown that if you compare cilta-cel with standard of care at this particular point of time, you see that the CAR T-cell therapy is far superior to the existing standard of care. Right? Chances of VGPR and CR are both much better in the cilta-cel arm than in the standard of care arm. All right, so these are the two products: ID-Captogene, which is less impressive than the best available CAR T product that was cilta-cel. And then there was a Chinese product from a company called Pregene in China. It was the PRG 1081. And that was shown that the ORR and the CR rate was almost as good as cilta-Captogene, right? Because of certain changes in the CAR T cell construct, which I don't have the time to explain for today. This product was bought over by Dr. Reddy's lab, which formed a company called Aurigene, an offshoot of Dr. Reddy's lab. And they have completed a phase 2 trial with anti-BCMA CAR using the Pregene product. It's awaiting the DCGI nod for marketing, and it's likely to be a very impressive product. And ImmunoAct in Mumbai has also started the phase 2 trial for their own BCMA product. So again, Aurigene uses a closed system of transaction, and ImmunoAct uses an open system of transaction. This was the data that Aurigene published with the phase 1 study, which had 10 patients. The product is called Swasth, right? And it showed that not 10 patients, 8 patients, and it showed a very favorable profile. And all these 8 patients had an excellent response of their myeloma after a median of some 5-6 lines of treatment. So coming to the last part of my lecture, the cost is a barrier for routine use. The tentative cost of CAR T-cell therapy in India is between 30 to 40 lakhs. Plus, there may be another 10 odd lakhs depending upon whether you're doing it in a corporate hospital or a non-corporate hospital. Whereas for Carvykti, somewhere around 5 crores is the cost of Carvykti, and plus an equal amount of cost for your staying in the United States, etc., whichever country you go to. So the cost exceeds about 10 crore actually if you decide to do this treatment abroad. CAR T-cell therapy is not easily covered by insurance companies, but we recently had 2 companies which completely covered the CAR T-cell therapy for their patients. Most Indians have limited mediclaims. That's another problem that we have, and no government scheme currently covers this treatment. Even though it may be curative for BA, ALL, or lymphoma, and unlikely that it will cover myeloma in future, in the recent future at least, but let's hope for the best. Cost, therefore, has to be borne out of pocket, and therefore only for the people who can afford this treatment can undergo it. Now, training or facility for CAR T-cell therapy has to be done in a multi-specialty institute with a good ICU backup. That's what you really need, okay? Preferably, of course, if a center is regularly doing allogeneic transplant and used to handling severe neutropenia and cytokine storms, that's a center which is definitely going to be able to perform a CAR T cell therapy. But you don't have to have this facility. Any good hospital with a good ICU backup and a trained hematologist, oncologist can do this. So now where is CAR T cell headed? Briefly, in the next two slides, I'm just going to tell you that it's going to come up very heavily in the rheumatology areas. Where you have, these, for lack of time, I can't explain, but this is also very interesting where, CAR T cell therapy is going to be used for SLE. It's already been published, but, chimeric autoantibody receptor is one of the mechanisms, and the other is CAR T regs have also been tried. And both these are very interesting, how you can treat autoimmune disorders with CAR T cell therapy. We are also having now dual CAR T constructs, so CD19 and CD22 CAR T cell therapy, or you can have a BCMA plus a GPRC5D for myeloma. So, multiple CAR T constructs are being tried with two separate vectors. And allogenic CAR T therapy is also being tried, where you can actually have a donor-derived CAR T and prepare that, and that will be off-the-shelf use, right? So you don't, the patient who is diseased won't have to undergo this procedure, won't have to have his autologous CAR T cells harvested. You can actually do it from a absolutely good, robust T cells from a normal individual. So with that, I come to the end of my lecture. These are the CARs of the future. I'm sure the future is going to be very, very exciting for CAR T cell therapy. And I thank you all, and I'll be happy to take questions.
Thank you, Samir. You made it very simplistic. I'm sure the students who are logged in, I presume in significant numbers, must have benefited a lot. And of course, we'll take up the questions. We have raised hand sign from Dr. Sushma. Please go ahead.
Hello, sir. Very nice class. Thank you for it. Sir, I have few questions. First is, what kind of bridging therapy would you use for a high dose, high disease burden lymphoma cases before collecting T cells for CAR?
So bridging therapy is after you collect the T cells. Okay, there's a slight difference. One is you can give cytoreductive treatment and then do your CAR T cell collection. The bridging treatment is after you've already collected your CAR T cells. You're then giving something to to get the disease down. Okay, so if you're asking me what bridging therapy I would use after collecting the T cells, then because there's a limit to what you can do before you collect CAR T cells. You can't give harsh treatments. Okay, so after you collected the cells, then you can afford to use typically what we may use for lymphoma would be a combination of rituximab. Sometimes we use polatuzumab with rituximab alone with some steroid. We may decide to use our Gemox. We may decide to use our 1 odd cycle of GDP. Or the choice is yours. It's up to you to decide what you're comfortable with and what the kind of disease burden you've got. The other interesting drug that has been used in this space is glofitamab, right? It's a bispecific T cell engager, which you can also use along with polatuzumab. It's like a very good regimen. That immunotherapy, no risk of causing too much of cytopenia with your bridging. So that's another combination that can be used.
Okay, sir. Thank you, sir. Sir, another question in the field of multiple myeloma. As we see our Indian population, we tend to get multiple myeloma slightly at a younger age. So
Yes.
if a younger patient comes to me tomorrow and money is not an issue, how do I advise to go up for the future treatments after induction therapy, sir? Should I take the patient upfront for auto SCT, or should I store the cells for future? And how do you counsel this patient for, especially for high risk multiple myelomas?
Are you asking also in the context of CAR T cell therapy? Because otherwise it will be a completely different discussion.
Yes, sir. Yes, sir. In the
Right.
context of CAR T.
Yeah, so for CAR T cell therapy, currently you have to have it is not approved for upfront use, right?
Yes,
It may
sir.
in future, we don't know. It's a very hot topic that can be discussed, but currently it is not for upfront use. Your upfront use has to be same, the standard induction therapy, whatever you choose, with an autologous stem cell transplant if the patient is eligible for it, and then followed by for my maintenance. And only after the patient has actually relapsed, it's approved for 3 lines of treatment, 3-line failure. right?
Yes.
But you can potentially use it for patients who have had at least a triple refractory or penta-refractory. In that category, you can use CAR T-cell therapy.
Okay, sir. Thank you, sir. Thank you, sir.
Thank you, Dr. Babita.
Anji. Thank you, sir. Dr. Sameer, thanks for the excellent talk. I have a very basic query that in the whole of the presentation, sir, you have not mentioned, you have said everything about the B cell malignancies. You have not said anything about the T cell malignancies, and I just want to know that whether it has any role in the T cell malignancies.
Yeah, interesting question. So, in T cells, there are centers in China and at MD Anderson. And so these centers have now developed a CD7 CAR T cell therapy. Okay, so it's not yet routinely used. It has been tried, and apparently a couple of centers in China are offering it now. But it's still a little experimental. We don't know the long-term data of this particular therapy. But so for T cell ALL, CD7 CAR has become very recently available, but not for any of the other T cell lymphomas. There it's only chemotherapy and that's it. Transplantation.
Sir, my second query is I have the basic queries that the T cell therapy it is understandable in T cell malignancies. What is the logic behind the T cell therapy? Though it is a specialized T cell, CAR T cell. So what is its logic in its effect in the B cell malignancies, sir? What is its logic behind?
Because T lymphocytes are they are naturally primed to destroy tumor cells, whether it is from B cell or otherwise, and therefore if you can take these cells and just strengthen them, modify them genetically, and make them express a T cell receptor that can bind to the correct sequence of nucleotides that can bind to the tumor antigen, then it's going to do its job, because that's the natural function of the T lymphocyte. That's the reason why T cells are harvested and made to do this treatment.
Sir, then my last query is that theoretically, sir, we know that this is effective in the multiple myeloma, B cell malignancies. Practically, I want to know that in India, whether it is available, one. Secondly, if it is available, if the answer is yes, then in which type of the malignancies we are using practically? What is the data, sir, which is available?
Yeah, so I kind of showed a little bit of the data already, but just to tell you in the real world, the ImmunoAct, I know that they have performed about 300 CAR T cell therapies in India after it became available in December of 2023. They've done about over 300 CAR T cell therapies, and I can tell you that the real world data is far better than the trial data, because now we have got used to how to do this treatment. The tricks of the trade we have learned, and therefore we are able to do it better. So even at our center, we are doing about 1 CAR T cell a month currently.
Right,
so it's
sir.
become routine practice now. But it's not available for myeloma. For myeloma, in somewhere around December of this year, the origin product will become available.
Okay. Thank you, sir. Thank you.
We'll take one question from the audience.
Yes,
Dr. Nilesh Shah has asked, what is the scientific reason for the rarity of neurotoxicity of CAR T cells in multiple myeloma?
Well, I just think that myeloma affecting the CNS is much rarer than B ALL or B lymphoma affecting the CNS, and that's probably the reason why you don't have much of ICANS in multiple myeloma.
Dr. Nishad, your question.
Sir, excellent talk. Just to share, we have done 2 CAR T cell therapies as of now. The first CAR T cell therapy we did was a 37-year-old female PH positive ALL. She's currently day 36 post CAR T cell, and she's landed up in severe cytopenia. So looks like it's a cartopenia. We have ruled out HLH. The bone marrow is in remission. It is hypocellular. I wanted to ask more about cartopenia. So when does it start? What is the timeline, and how do you manage such cartopenia? She has an ANC of just 10.
Yeah, thanks, Nishad. For lack of time, I didn't discuss that part in too much detail. But there is in blood there's an article of how I treat cartopenia post CAR T cell therapy. So you can go through that in detail. You describe very well in that. But cartopenia is probably the only situation where with cytopenia you are happy. You want that cartopenia to happen, because this gives you a definitely better chance of disease-free survival than if nothing happens to the patient. Either you have to have CRS or you have to have cartopenia. You're more sure that the disease is likely to be cured. So cartopenia is nothing but just waiting and observing, supporting, and that's it. It can last sometimes for a long time. It can be a little what shall I say, irritating, I would say. May last for something like a few months. You just have to support with growth factors, as and when required, support with immunoglobulins if your IgG levels are low. And in majority of the situation, it sort of just improves.
So regarding myeloma, I have one question. What is the disease-free interval, after a CAR T cell for myeloma?
The what?
The disease-free interval after a CAR T for myeloma.
Disease-free, we have only the, if I tell you what it is with the best product, Cilta-cel, 47% at 3 years disease control period. So, it's looking pretty good. And hopefully, the origin product is also, it's a nanobody, it is likely to work well. And we hope that, it also gives us good, but at least I would say upward of 2 years should be, we can expect.
Thank you, sir.
Thank you. Take one question from the audience. Dr. Aditi Goyal wants to know, first of all, she's congratulated you for a wonderful and simplistic talk. And then she wants to know, are there early markers to predict CRS? And can we risk stratify patients before infusing?
For CRS, well, I would say at the moment it is the disease burden. If you have a higher disease burden, you've got a higher chance of developing a CRS. And your cell dose, the higher the cell dose, the more likely that you're going to develop more CRS. But other than that, I would say it's rather difficult to predict it. There is a CAR hematotox score, which you can go through, and that also will help you about, in guiding certain complications that may happen, especially the cytopenias.
Thank you. She has another question, whether CAR T is likely to replace stem cell therapy.
That's $1 million question. Nobody has the answer to that, but in a good number of patients, it might, and especially in those patients whom we feel are unfit for allogenic transplant in view of age or comorbidities or simply the lack of, the patients are, sometimes they just don't want to go through the process of an allogenic transplant, and their CAR T cell definitely has an edge.
Thank you. Nikhil, your question.
Excellent lecture, Dr. Sameer. That's a very simplistic and comprehensive way you've covered the topic. I have a couple of questions regarding few patients that we have been screening for CAR T cell of late. So we have a couple of patients whom we had considered for CAR T, but developed CMV infection, EBV-related viral infections in between. So what would be your approach before taking these patients for CAR T cell?
This is for ALL lymphoma?
This is for lymphoma. Sorry.
So I mean, there's no clear answer to this, Nikhil. As you know, you're well versed with CAR T cell therapy, and there's no clear answer to this. You have to, it depends upon the patient. There's no one answer. If you've got CMV infection, naturally you want to treat it before you're going to collect your T lymphocytes, right? You obviously want to clear that out. It depends on what the burden of your disease is. Because definitely I would try and give good therapy, get the disease out first. EBV, of course, you give rituximab generally in 2 doses. Most patients will show a good response, and only after that I would venture into collecting my cells and actually preparing the CAR Ts. It is inappropriate, I feel, that you have an infected patient and you're collecting his lymphocytes and sending them for CAR T production.
And same way, a similar patient who had actually developed lymphoma-related secondary HLH. So despite treatment, despite getting the disease under control, the ferritin levels hover somewhere between 5,000 to 10,000. And again, this patient also has a EBV viral load. It went all the way up to 4-5 lakhs. Now it's come down to 10-20,000, but it is not completely clear despite rituximab and multiple lines of treatment, and despite the fact that lymphoma is in CR. So again, one of these patients who doesn't have much of a treatment option left had a refractory disease. So we were just contemplating how long could we wait on collecting the CAR T cells for this patient.
Yeah. So you just have to make sure that this is not chronic active EBV, which is a very, very bad situation to have. There it's going to be, very tough. But if it's not that, and if it is just EBV infection, then, well, I guess if your lymphoma is running away, then I would definitely collect the cells and proceed. But otherwise, I would strive to get the EBV under control. If the lymphoma is reasonably, not sort of, under reasonable control. So, again, as I said, no clear answer to this question. You have to look at what the disease burden of the lymphoma is.
And Dr. Samir, any experience in performing Immunoact CAR-T for post-transplant lymphoproliferative disorder?
No, I don't have. I'm not sure if there was in the trial, but I don't think so. No, I don't have any personal experience.
Okay. And in your lymphoma patients, practically, when do you collect the T cells? Like if a patient with a refractory disease or a relapsed disease comes, would you collect T cells after a couple of cycles? So when do you collect the T cells and how many cycles do you typically give before taking them for a CAR-T?
So as I mentioned, if it's minimal disease burden, I would collect immediately and give
Right.
my bridging and then infuse. If it's a high disease burden, then I would first get the disease under control with agents other than pyronucleoside analogs and bendamustine, etc. Try to give immunotherapy as much as possible. Get the disease burden to make sure that the disease is actually responding to your initial treatment, and then only collect the cells.
Okay. Once again, wonderful talk. Thank you.
Thank you.
Thank you, Nikhil. Dinesh?
Sorry, sir. Just want to ask you what are your recommendations with the Indian CAR-T regarding the transplant in ALL? What you suggest? And we don't have that this NGS MRD.
Yeah. I know. No, so I would still say that for ALL in India, currently you must first go the standard way. If you've got a relapsed ALL, you've treated him with whatever immunotherapy or a salvage chemotherapy, whatever you've done. If you've achieved an MRD negative state, please go for transplant, not for CAR-T, because we don't have really long-term data. So go for transplant there. If you have a disease where you've not been able to achieve MRD negativity, achieve that with a CAR-T cell therapy, and then whether to go for transplant or not is a calculated decision. If you feel it was a very high risk disease, then follow up your CAR-T with a transplant. 6 months after the CAR-T cell therapy, you go for a transplant. If you feel that the patient is unlikely to tolerate the transplant, he might actually die because of the transplant, then go for the CAR-T cell therapy alone. If you've achieved an excellent response, then just sit tight and wait. If he relapses, then we'll see.
It's very difficult to say.
It's a difficult, it's a difficult question. There's no clear answer to this.
Thanks, Samir.
Thank you, Dinesh. One more question from the audience. What are the long-term toxicities of CAR-T?
I am honestly not sure what the really long-term toxicities might be. I don't, probably they may not be anything beyond 5-6 years, but we really have to wait and see. Yeah, malignancies rising from the CAR-T cells, those are all very rare chances, but that might be one of the things.
Is scartopenia can last lifelong?
6 months approximately.
It doesn't last lifelong, it recovers.
No, it recovers.
And this Parkinsonism-like syndrome?
I have heard of it, but I'm not sure too much about it, sir. There is one. There are talks about it, but I'm not sure.
Chirag, your question.
Yes, Samir, excellent talk. DLBCL primary refractory. Now, the options are limited to bring them to a good PR. And so if you have such a case, would you say that, cost is not an issue and there is nothing else left to do? Would you recommend CAR-T?
Yes, definitely. Of course, depends upon what kind of a response you assume. You have a large, bulky mass and you've given treatment and nothing is moved, then the chance of CAR-T cell curing that is going to be quite slim. But if you had a reasonable response with even radiation, radiation is a good sensitizer for CAR-T cell therapy. So you give, probably in that patient, I might consider using a bispecific antibody. The polatuzumab or glofitamab combination, try and achieve a best possible response, maybe radiation and then CAR-T cell therapy.
Sometimes you just, these are difficult patients. And
those are very difficult patients.
Yeah,
yes.
I have somebody recently failed all of these, including polatuzumab. So not glofitamab, of course, but yeah. And for this scartopenia, can you give granulocyte transfusion?
Yes,
Is
you
that safe?
can depend. You can if it is a severe cardiopenia and the patient has got something like a fungal infection. Then of course you will consider granuloside transfusions.
Even MDR for our setup, people would die of
Yes.
the sepsis.
Yes.
So it's nothing contraindicated, at least in
No,
that
no, not at
sense.
all.
It's something to
Not
do
at
with
all.
the mechanism of CAR-T working.
No, not at all.
Okay. Okay. And for the this high risk myeloma, would you still transplant first, or because the post transplant myeloma autologous transplant, the outcome in a high risk disease, especially triple hit, is not great. So instead of transplant, would you take them up directly for
So,
CAR-T?
to answer that question, the Cartitude-5 and the Cartitude-6 trials, you may know about them. The Cartitude-6 trial is the one which is clearly going to answer your question. It's an ongoing trial in which patients will be, so in the Cartitude-5, it's VRD, autologous transplant and LEN maintenance versus VRD induction, cilta-cel, and then LEN maintenance. That's the schema. And in Cartitude-6, it is DARA VRD induction followed by autologous transplant and LEN maintenance versus DARA VRD, cilta-cel infusion and LEN maintenance. So that is going to answer your question.
Thank you.
Thank you, Chirag. Another question from the audience. Dr. Darshana Rane. What is the most common cause of death following CAR-T?
I would say it is CRS followed by IEC-HS. That's a bad combination. And subsequently, at that point of time, if you have organ dysfunction along with a secondary infection, that's the scene when it's difficult for the patient to survive. The mortality is under 5%, but I would say IEC-HS is one of the most dangerous things that can happen in a CAR T-cell therapy.
Thank you. Rajat, your question.
Yeah, sorry, Sami, wonderful question. Just talking that the first CAR-T we did in Calcutta, the lymphoma patient, low volume, developed IEC-HS and then had a seromonas sepsis and died. That was very traumatic for me. So that, is a problem. I had two comments to make. The T-ALL CAR, though Singapore has, Dario Campana has been making fratricide resistant CD7 CAR. So he pebbles it. So the CD7 is inside. So they become fratricide resistant. He's been actually doing it for about 22 patients they have done with excellent results. And then not all of them actually went for the transplant. Some of them survived even with some CD7 negative CAR T cells. And the other comment I wanted to make was that the question about transplant and CAR T. In pediatric ALL, what happened in Singapore when we offered some families transplant for high risk ALL, and then offered that we do have another option of doing CAR T. They all went for CAR T, knowing it was not an approved product. And what drove them to the decision, of course, cost was not an option, was the toxicity.
Yes,
TBI-based toxicity. So this is something which we have to, yes, all the things are there, but the parents sometimes will go for it. So that was very interesting. My question, one question I have to you, the B-cell aplasia post-CAR T, many of them will have a pre-existing very deep B-cell aplasia, which we don't look for always. And then if those patients go for a CAR T with a very low disease volume, like many of them go on to MRD remission, is that a problem? So their pre-existing B-cell aplasia and then they're MRD negative by the time already you were prepared for CAR and even bridging and they become very low level. Will the CAR T expand? Will that persist? Any idea?
Yes, they very well will, because they're going to see the tumor is there obviously, so they're going to see the tumor. I don't think so. They surely won't have the kind of B-cell aplasia that would happen after a CD19 CAR, right? Because they would have certain amount of B-cell, I would say aplasia. Maybe the B cells would naturally be suppressed, but I don't think it is, it's directly proportional. Ultimately, it's that if they are CD19 positive cells, the CAR T cells are going to destroy them. So I'm not sure whether it would be whether the B-cell aplasia that you're talking about with the active malignancy would be so severe.
Okay. Thank you.
Thank you, Rajat. Dr. P. Suresh has a question in the chat box. Role of CAR T in lymphoma in HIV patients and in SCID patients.
I don't know the answer to SCID patients, but I'm not sure why you would do CAR T in a SCID. I don't see the reason why you would do it, sir. I didn't get the question for SCID. In a HIV patient, if he's got a lymphoma, I would do CAR T, but I'm not sure about this.
Yeah, question is about lymphoma in these patients.
Okay. Well, it's going to be a very, very tough situation. I'm not sure. I've not seen a patient, or nor have I read about SCID and lymphoma. But I think, I guess, with the attendant, if you're able to handle the attendant complications, you might decide to do it. But I'm not sure about SCID. Honestly, I don't know. Have a clear answer. I would need time to think about that. But in HIV lymphoma, yes, it can be done. We do transplants in HIV patients, and therefore we can very well do CAR.
Here's another question. Do you anticipate the CAR T to be equally successful for solid tumors?
No, I don't think so. As of now, no. But maybe in the future, well-designed CARs, further research, it might. Currently, it's not as useful as it is for B-cell lymphomas.
Samir, do you see CAR NK in near future?
CAR NKs, I'm not sure about because a lot of treatments with NKs have been tried, including, haploidentical transplants with NK cell infusions. It's been tried in Vellore as well, but somehow that NK cell therapy has not, met its, what shall I say, its target, I would say. And therefore it's not yet, although it comes up every now and then, it doesn't live up to its expectations. So I'm not sure about this, sir.
Thank you. Dr. Manasa Kakunje.
Yeah, thank you for the excellent talk, sir. Thank you for the opportunity to be a part of this, sir. My question is regarding the disease burden. We know that if the lower the disease burden, the lesser the chance that it works. But then, is there a cutoff, with respect to the disease burden beyond which we definitely know it's not going to work? Like in Blina, we take MRD, morphologically 5% blast. We know more than that, it doesn't work. So in CAR T, is there a cutoff like that?
There is no cutoff like that. It's an art which you have to learn to use correctly. So it's not, there's no clear answer to that. To answer this question, one of the first patients that we took up had a massive disease burden. We just infused the CARs. The patient died of, everything that, all the complications of CAR T cell therapy that could happen to that patient. But the disease was in complete control at the end of, 1 month of treatment. It was a large, bulky mass. Everything just went away. The patient actually passed away because he was elderly and he had all these complications. But, the disease did go away, so it's not always, that the higher tumor burden will not respond. It's very unpredictable. You can't be sure. But in general, a manageable disease, a few lymph nodes here and there is fine. But if you have large, bulky disease, then you would definitely want to get it down to manageable levels. It's no clear cutoff. I can't tell you in centimeters how much the size should be.
Okay. Thank you, sir. Thank you.
Okay. Samir, what's the...
Can I make a small comment here?
Yeah.
Interesting. So there's a cutoff of 5% apparently leukemia. That's like the Michael Pulsipher's paper has showed. 5% blast before CAR T infusion, you should get it down below 5%. That's the paper suggested. And I was hearing Stephen Graf in Singapore a month ago, and he said it's a nonsense. He said, most of his patients had it in a very high level disease. He said, CAR Ts are so effective, they will control it. Only problem is you'll have more toxicity, as Samir has been mentioned. So your T cells are such potent, even few T cells will probably control. You know the story of one T cell killing a pound of CLL cells. There's a story about it. So these are very potent. So we don't know the answer, but yes, we'll get more toxicity, but it may be effective also. Okay.
Thank you, sir.
Thank you. What's the average indoor stay duration for CAR-T? And after that, how long the patient has to remain in close vicinity of your institute?
So currently, if it's ALL, we admit the patient for the conditioning chemotherapy as well. But if it's a lymphoma, we just do it on OPD basis. The fludarabine cyclophosphamide, admit the patient only for from the day of CAR-T infusion, and then subsequently we keep the patient admitted for a minimum of 1 week, and sometimes longer if there are complications. So by day 7, 8, if there is no CRS, no problem at all, just some cytopenia which is recovering, then we discharge the patient. In ALL, typically the stays are a little longer because it's a marrow disease, so the cytopenia is expected to be a little more sometimes. So it's roughly about 10 days, I would say.
The second part is how long the patient has to remain in the vicinity of your institute?
I would say a month.
Dr. Nilesh, your question. Nilesh is probably not there. Nishad, you have
Yeah, I am here, sir.
Go ahead.
Sorry. Yeah, this is for you and Dr. Samir both. I read somewhere that there are kind of self-destruct CAR-T cells available. I do not know whether they are still experimental stage or not, but these are the CAR-T cells who destroy themselves, by undergoing
Yes.
apoptosis after the work is done, after the tumor cells are destroyed.
Yes.
And if it is available, it would be a very welcome thing because that will alleviate the danger of the prolonged cytopenias and the consequences. Is that
Yes,
kind of thing available?
Yeah, it is not available commercially, but I know what you're talking about. So these cells are with if you're having a very high toxicity like CRS, etc., then you could send a suicide signal and the cells will just sort of undergo apoptosis. But somehow I'm not sure whether that is really required because as it with available CAR-T cell therapies also, we see that the mortality is very, very low. So it doesn't make too much of sense to have those kind of cells.
Okay, and then there are some armored CAR-T cells. That
Yeah,
also.
those are the 4th generation CAR-T cells, and they are sort of, but the ones which were in routine practice are still 2nd generation. Those cells, are not yet commercially available.
Would and once they are produced and used clinically, would they be effective against solid tumors?
We don't. Maybe.
Anyway, thank you very much, sir. Thank you.
Another question in the chat box. Wants to know the development of CRS and HS have any predictive role in persistence of T cells or long-term control of the disease?
No, I don't. So yes, so persistence of this thing, I can't be sure, but long-term control of the disease, in general, it is, although there is no clear, evidence that, you have to have a CRS for a disease to be controlled. It's like, saying that, when you have a little bit of graft versus host disease, we are often sure that the transplant is going to work better. Similarly, if you have CRS, you at least know that there's a surrogate indicator that the CAR-T cells are working, they are active, and therefore a higher chance that the patient is going to remain in good response. ICHS, on the other hand, I'm not sure whether that correlates clearly with better survival. But yes, and that just indicates that that there is ICHS is probably more because of the macrophages which are being activated. So they may or may not really have an impact on the long-term disease-free survival. But CRS is clearly because directly induced by the CAR-T cells, and yes, that will indicate that probably the patient is going to respond better.
Thank you. Nishad, your question?
Sir, is there any correlation between the CAR-T cell dose and the complications of CRS, HS, anything?
Yes, there is in general. So, that first patient whom we had, who we died, the one I just spoke about, we had infused about 18 million cells. That time it was very naive. We are not very sure. We didn't know what the exact dose should be. We gave 18 million cells and we ended up with complications. So you should not have a very high cell dose, generally between 5 to 10 but of course, it depends on the product, right? So right now I'm talking about the ImmunoAct product because that's the one which we use more commonly. And there it should be between 5 to 10 for a lymphoma and about 3 to 5 for a ALL.
Sir, in a case of BALL with MRD negative, haplo versus CAR T cell, do you have any preference?
It depends on the patient. It's difficult to say, but somebody who would not be able to withstand the haploidentical transplant, I may consider CAR T and take my chances, although there's no long-term data. But in general, since I'm reasonably confident with doing haploidentical transplants, I would prefer haplo for that patient, because I can give a better sort of I can predict better. This is big going from the past experience. I would go for a haplo transplant first. It's not yet the long-term results are not out yet. 5 years later, we might again revisit this question.
Sir, last question. Role of stem cell boost in cartopenia. What is that stem cell boost and what is the role of stem cell boost?
I haven't read too much about it, Nishad. Have you heard anything about this? About stem cell? Stem cell boost are routinely used in, in a poor graft function in an allogeneic transplant, but I don't know about this.
Sir, I just read that one line. Just read that one line. I don't know anything about it.
It is that in myeloma patients, when you are collecting the stem cells for autologous transplant, you preserve the stem cells, like we sometimes do for the second autologous transplant. And these stem cells which have been preserved can be used for those patients who have got very severe and prolonged cartopenia. So that is stem cell boost. But in stem cell preservation for myeloma patient itself is a rarity. Majority of the time you just collect and do it. You don't preserve them.
Sure.
Thank you, sir.
Right. One more question is from Dr. Bhavani. Yeah, that's about, do you foresee CAR T for myeloid disorders in near future?
Near future, no. Distant future, maybe.
Okay. Dr. Rashmi Kushwaha.
Sir, good evening. Thank you for the simplified talk. And thank you, Agarwal sir, for giving me an opportunity to be here. Sir, my question is little out of box, but I was thinking that is there any future of using this CAR T cell therapy in inhibitor positive hemophilia patients? Because inhibitor positivity is causing a lot of burden on the treatment aspect also. So probably is it being used somewhere in the world or?
No.
There's just a case report published, I think 2 weeks ago. I'll send it to you. Inaccurate hemophilia.
How does it work, Rajat?
It just kills B cells. So it's inhibits antibody production. So
surely there are safer treatments and more feasible treatments for inhibitor for hemophilia. You can't imagine doing a CAR T cell therapy for that.
No, the case report is about that everything failed. So you used the CD19 CAR T and the inhibitor levels went down. There's a case report. Interesting.
Sir, it is published in which journal?
Yeah, it's I'll send to you. I'll send to Dr. Agarwal. I have it.
Sure, sir. Fine, sir. Thank you so much, sir. Thank you, sir.
It is like SLE and other systemic autoimmune disease. Autoimmune disease. I think that's the last question. I don't have any more questions in the chat box. Anybody here wants to ask anything? No.
Sir, may I ask a question, sir? Dr. Muralidharan.
Please go ahead.
Sir, I just want to have a CAR T in extramedullary disease in multiple myeloma or ALL. What's your experience there?
No, I have no personal experience, but purely from the literature, it does work. In plasmacytomas, the bispecifics and CAR T do work for extramedullary disease as well. So yes, it can be used in that scenario.
Including the CS.
One, just as a last comment, one of the really innovative treatments that might happen in future, which people have done already in Australia and as well in China as well, is where in an ALL, you can, when a really high risk ALL, one of the treatment strategies that can be done is you do a haploidentical transplant using TCR alpha beta deplete, transplant where you're infusing only the stem cells of the donor, and from the donor you derive CAR T cells. And donor-derived CAR Ts can be co-infused along with this, and that will probably have it's like a combination of appropriate CAR T cell therapy that is donor-derived, and to have the best possible graft versus leukemia effect, and to generate new T lymphocytes from the donor that would also, in addition, take care of the long-term disease burden. So that's another very interesting strategy that some people have tried.
Wonderful. Thank you. So thank you, Samir, for sparing your Sunday afternoon. And I hope everybody has benefited, and the student community must have very, very benefited, because your talk was really made very simplistic. Thank you.
Thank you, sir, for the opportunity.
Bye-bye. Bye.
Thank you, sir.
Thank you, sir. Good night.
Good night.
Bye.
Good night.